This is a 17-year-old athlete, female athlete, presented to us with pain along the anteromedial aspect of the foot for 1.5 years of age. For 1.5 years. So her main problem was that she was having difficulty to participate in sports activities, and she wanted to get involved in state level athletics. So she was initially evaluated by a local medical practitioners, and the X-ray was declared to be normal. And she was also treated with local steroid injections, and she also underwent some Ayurvedic medication for the same. On examination, there was focal tenderness over the dorsal aspect of the medial midfoot. The talocrural joint had normal plantar flexion, but inversion and diversion were normal. Dorsiflexion was a little restricted. She had movements of about 0 to 20 degrees, and further movements were painful. The plantar flexion was about 0 to 40 degrees. So this was the X-ray, this patient.
Yeah, any further imaging?
So we did a CT also, and we could find this, the CT, where there was a fracture of the navicular bone.
Okay, so how, any comments, anyone has seen a navicular injury, and how do you differentiate this from a bipartite navicular?
Sir, in a bipartite navicular, usually the navicular is comma shaped, and in the lateral views, if you see, the dorsal aspect of the navicular bone it is in a triangular shaped in a bipartite navicular in the lateral views. But in this case, you can see the fracture fragments or ends are sclerotic, and there's a irregular fracture surfaces.
So Sheetal, any experience with this type of injury, fracture of the navicular?
She is an athlete, sir, and we are thinking of a stress fracture of the navicular. Yeah. So almost 1.5 years of since she's having the pain for 1.5 years.
Yeah, I usually would get MRI to see the edema around the bone to see how active it is. But we have treated several of this. This requires fixation because navicular is very difficult to heal. Just like scaphoid, same thing with the navicular. So if you have a fracture, it's not going to heal just with rest. It may become asymptomatic, but if your goal is to unite it, then it needs a screw fixation or K-wire fixation. We have done it in trauma patients, we have done it in these kind of, the only thing is you have to differentiate bipartite, and he was right the way he described it, that it has a typical shape, the bipartite navicular. But this bone needs fixation whenever you have a fracture. Unless your goal is just to make it asymptomatic, you can cast and let them see how they do, but typically needs fixation.
So interesting, you are seeing it quite commonly. So anyone of us, anyone else has seen this fracture? Okay. So go ahead, how did you manage this?
So we opened the fracture site, and we found that the fracture ends were freshened, and we found a gap of about 3 millimeters. So a iliac crest graft was taken and was placed at the fracture site, and we fixed it with the cancellous screws. So this is the immediate post-op X-ray, and this is the 6 months follow-up, and we did a CT also which showed complete union. So and the re-op protocol was the below knee cast was applied, and she was immobilized for a period of 6 weeks. After 6 weeks, she was mobilized partial weight bearing, and full weight bearing was started at 10 weeks. Now she has returned to sports activities. So I would like to present the second case also.
Yeah, you can run through that as well.
Yes, sir. This is a 14 years boy who is a football player and presented to us with midfoot pain for 3 months. And he initially underwent native bandaging, and there was no associated symptoms. So this was the X-ray of this patient, and this was the CT image. This patient. So this was also we located the fracture. The fracture ends were freshened, and we did a open reduction and fixation. And for this patient, we took a proximal tibia graft. And this is the follow-up X-ray at 3 months. So, yes, sir. So, on coming to the discussion part, it was initially described in 1970 as a stress fracture of the tarsal navicular. Fractures usually occurs in the sagittal plane, and the central part of the navicular is relatively avascular, and because of repeated stress, usually it goes into non-union. And we also found that only one case has been reported in the literature with navicular stress fractures who presented with non-unions. So non-unions are quite common in adults, but in children it is quite rare. So this is one of the presentations that we saw in one of the literatures. And CT is the choice of investigation when we are suspecting a navicular, non-unions, but in stress fractures, as Sir said, we can do an MRI also. So in acute fractures, conservative management is a treatment line, and in non-union, we can go with the internal fixation and grafting.